While all the speakers are coming up, Tom, I have a question about your presentation. When you were looking in the study, looking at genotyping and prediction of SIN2 plus in patients with atypical glandular cells, we know that a lot of SIN2s and SIN3s are not 16/18 positive. But I think the thing many of us worry about with atypical glandular cells is glandular neoplasia. And would you not expect the vast majority of the AISs to be 16 or 18 as well as the adenocarcinomas?
I would, and that's the reason that I said that if we utilize 16/18 as something to make our post-colposcopy with a negative finding of greater concern, that's what I'd be concerned about missing. That's why I said I would take, if I knew they were 16/8 positive, I would take a lot of biopsies, even in areas of ectopy that look normal. I would do that anyway with Agus, but I would be more concerned if it's 16/18 positive. And I really want to evaluate the canal. And Dr. Stoller and I had a discussion about this beforehand, and he was saying that he would, you know, he thinks that's high enough risk, 16/18 positive, negative colpo, Agus not otherwise specified, that he would put them in a possible cone situation. We don't have guidelines on that, but that was his. So it's just an indication, again, of our concern of how much risk there is in that situation and how hard it is sometimes to find adenocarcinoma in situ. I don't know whether Walter has any thoughts on that.
No, I would agree with you. I really would. I want to make two other points about your talk. The first one is that I really do agree it's better to do a single excision than multiple. And I think straight wire is just as good. Second one is I plead that we drop conization and go to type 3 excisions, because I think it's clearly understood. And no, I agree with you on the other point. The only problem about HPV testing, of course, is that for everything else, it's negative predictive value that's wonderful. But with AIS, its negative predictive value is yes, less useful because of the extra cervical disease that may be there. So we just need to be a little bit careful about having a negative HPV test with AIS. Doesn't mean you shouldn't keep looking outside the cervix.
Yeah, I hope we made that clear, actually.
So,
yeah.
Do
Any questions? Yes.
Yeah, do we have some questions? Please make these guys work for their
I have a comment on AIS. We looked at our series. It's, I think, 400,000 women. We did full genotyping always. And if you look at AIS, you only find HPV 16 and 18. And if I look at your numbers, you actually see that your HPV test, it's probably not sensitive enough, because for AIS, you have less HPV copies in the tumor cell, and so you can wait longer to have a higher load to detect it. But if you have a more sensitive test, you actually only pick up 16, 18, and you pick up more 18 than 16.
Well, there's another factor related to the sensitivity. The main problem in my mind is not, I agree with you that the average copy per cell in AIS is very low in many cases, but the real problem is that the AIS is up in the canal and our screening methods don't sample up in the canal. So you have two factors for the sensitivity issue. One is, do you actually sample the cells in question? Two, do you have enough of them to trigger the positivity of the test?
Because we were aware of that problem, we changed the brush type in 2005. And on the 1st of January 2005, we went to before we had the cervix brush, and from 2005, we introduced the cervix brush combi with a little endocervic brush in the middle, and we actually showed that when you use this device, you have a better sampling. You have a better sampling.
I would agree with that. We use the same combination.
I agree with everything you said. I think in the Athena trial, where 50,000 women were screened, my memory was that there were 6 AISs and that 3 were HPV 16 and 3 were HPV 18. In other words, they were all 16 or 18. So again, it's the reason why I would be concerned with an Agus Pap with a 16, 18 that I didn't find anything. It may be that there isn't anything there, but it does make you more concerned.
Other questions, please step
Yeah,
up.
can I ask a question to Mark Schiffman? What you presented was, I think, a very elegant way of setting up new guidelines. It's a very logical and elegant way of thinking. But in a way, it's based on the underlying assumption that what was done previously was actually correct. Because you're putting the same percent, what's the same percentage to the same category. And I was just wondering, how was that discussed in your panel when you set up your new guidelines?
It was the assumption, you're absolutely correct, that we weren't going about changing what we were doing. We were just introducing a new technique into the current framework. So you've got it completely right.
Well, I'd like to add one point to that, which is that we understand as this moves to maybe a risk calculator, one of the most important things that you can integrate into that calculation is past history. That, what the risk of the woman coming into the screening or the colposcopy or whatever the approach, whatever the level of management is, that a priori risk is going to influence the downstream risk of all the procedures and interventions.
There's a huge move in the U.S. now, and I'm sure in many of your other countries represented here, to go to a much more patient-centered determination of how do you act on risk and harms benefits determination. And I think over the next 5 years, we're going to see not just a group of senior expert people coming up with recommendations, but it's going to have much more practicing clinicians and patients having input into management decisions.
And I'm sure that's true. May I add just one other small point, and that is that the risk assessment from all of the calculations that you've made depend, of course, on the reporting rate of the relevant laboratory. And reporting rates for abnormality for ASCUS can vary from 1% right up to 10%, which is in the Irish screening program, which is a 10-fold increase. And our smears were sent to Quest in the US. And their reporting rate for ASCUS was much higher than even their reporting rate for ASCUS in the US. I don't know why.
You're paying them enough.
Something like that, something like that. Or they had to repeat the test again. Please don't quote me on that. I fear litigation.
I wanted to raise one question as I was listening, because I've listened to you, Walter, and I've listened to you, Tom, and the ASCCP and the Europeans discuss this colposcopy. And I always walk away from the meetings in this debate of number of biopsies and how we should do colposcopy. And if I didn't know better, or even I do know better, and I come away not certain what to come away with the story. And I would almost, let me say it as a challenge, which is that the two organizations have to come together. They have to adjudicate these discrepancies and come up with a universal standard for colposcopy. Because I think one of the problems is for any person in the audience, including me, is that we walk away and say, 1 biopsy, 2 biopsies, random biopsy, no random biopsy. Only the Europeans do it right. No, the Americans do it right in their numbers. And I think we have to close this loop here, that I think this notion that whatever the right way to do it is, and I don't know, I'm not a doctor, I don't even play one on television, but we have to close this. This debate's been going on for many, many IPV meetings, and I think it's got to stop. And we have to send a universal message, come up with universal guidelines on doing colposcopy.
Right. I actually think the recommendations from the SUCCEED trial actually are appropriate recommendations. That that 2 or 3 directed biopsies to the most abnormal areas makes sense. That just helps cover some of the fact that sometimes there's some lesions that don't look as striking as others that may still be important. I still question, like I did in the lecture, I don't know these very thin, very small CN3s. I don't think we know what the natural history of those is yet. We may be chasing rainbows, but it's hard once you find that those rainbows are there and not to try to find them. So that's been the issue. But the other issue is that in the United States, everybody can do colposcopy with just go to a course and do colposcopy. And in Great Britain and some other areas, you really, Victoria, British Columbia, whatever, in the British Columbia area, you know, they have expert colposcopists. They're trained to do that. That's mostly what they do. I think, you know, even though most of our studies would show that there isn't much variation between less expert and more expert colposcopists, it may be because we don't really have just these absolutely highly trained colposcopists like they do in other areas that we see so much variability. I'll let Walter pick up on that one.
Well, you've said pretty well everything I was going to say, Tom. I really do agree with you. I think it's apples and oranges. Colposcopy is not a single entity. In many Eastern European countries, not many, but several, a colposcopy is performed on every single patient who comes to the clinic, independent of whether they've got an abnormal smear, an ovarian cyst, or anything else. Whereas in other European countries, colposcopy is only performed for a screen-positive woman. And if in the UK, where I will not be allowed to do colposcopy unless I continue to see at least 50 abnormal smears a year, women with high-grade abnormality. You can't practice colposcopy unless you've been properly trained, accredited, your service is quality assured, and you re-accredit every 3 years. My understanding is that there are many parts of the world where anybody can do colposcopy. And I think that to ask for the same guidelines for a person who really hasn't gone through a proper training program, as you do for somebody who does an awful lot of colposcopy, is not fair.
Well, let me clarify. I wasn't saying that you should. I'm saying, do we want to recommend that there's a certain level of training and education that's part of this? I mean, and or that there, if you're not, then there's another set of guidelines which might be multiple biopsies or whatever it might be.
Well, then I think you're getting close.
But the problem is, and I'm being very simplistic here, is that the messaging that goes out between the debates or the discussions or the data that's being presented is very different, and it sends a mixed message.
Okay, if you're looking for global recommendations, it's more difficult. And I'm sorry to hog the microphone. I will stop, Mark, I promise. But if you're going to make recommendations for a particular country where the standard of colposcopy is X, then those recommendations pertain. But they don't pertain to every other country. In the same way that the risk assessment for an abnormal smear and HPV positivity depends on the reporting rate of the abnormality. And if you've got 1 in 10 women with an ascus smear, the risk of that meaning something is infinitely less than if you've got an ascus reporting rate of 1%. I'll stop.
You have a question?
Yes, well, it's actually a comment because you started by saying how you were going to calculate. What I miss here is the improvement. Because actually we don't want more colposcopy, we want less colposcopy and find more disease and less disease or SIN1 lesions. So, and I don't find this in your presentations. You talk about colposcopy and what to see and what to do, but not how to have it more efficient. If you look at primary HPV screening versus cytology primary screening, less women die, and you probably do less colposcopy and biopsies because you only have 1 round. So why not try to combine the test you do and to make it more efficient? Because from what I understood is that you are doing both tests, HPV and cytology, separately. Why don't you combine the tests and do one test after the other if you're going to do them anyway?
Dr. Schiffman, I think this is our last question.
In the United States, sensitivity is supreme, so there's a slight sensitivity increase to do both HPV and cytology together at the same time. People could argue that on a public health basis that that's not correct and you should do HPV alone, but that very tiny but measurable sensitivity advantage is what led people to still use both methods.
Mimo.
Well, one question on to Walter was how was he presented the 5% of CIM3 were detected after the first colposcopy. By the obvious question is how intensive they were searched. This can be, if you don't repeat any colposcopy, you will find any lesion after. I have a general comment. I think that it is very important in the countries where we have a good registration of colposcopies and of histologies and of cancers, to look at the screening history of CIN detected, at the risk of CIN detected after a negative colposcopy, but also the risk of cancer. My feeling is that you find less colposcopies, less CM3 after the first, just because you did not repeat. But my feeling is that many lesions which are missed at the first colposcopy will regress spontaneously and will not become an invasive cancer. So what I should suggest is to try to put our databases together and look at that. And so this we could close the discussion with data.
First of all, the fact that the Kitchener-Kelly study in the UK of low-grade smears found much more CIN at the first examination than did the ALT study. They found, both studies found the same amount of CIN, 3, but the UK study found it at the first examination, 95% of it. And the second point to your question was that the follow-up in both of the two large studies I quoted was 4 years with annual cytology and an exit colposcopy. It's 4 years and it's ongoing. Thank you. They're the answer to the two questions you asked me.
Thank you.